Bismillahirrahmanirrahim. Assalamu alaikum everyone. Welcome to our Sina antibody classroom. I am Mohammad Farid Alam with you. Today our discussion is diuretics. In this lecture, we will discuss the diuretics in very big details. Okay. What is the definition of diuretics? Diuretics is the drug which will increase the urine volume. So, if we inhibit the ion transporter, it will work as a diuretics. If we inhibit the carbonic anhydrase, it will work as a diuretics. If we block the aldosterone receptor, it will work as a diuretics. If we use the osmotic diuretics like mannitol urea, it will also work as a diuretics, which will eventually increase the urine volume. If this is the renal artery, from here it breaks down into afferent arteriole and efferent arterioles. So from here, like, blood will come. In this blood we have plasma. So by the glomerulus, protein free plasma will be filtered. So in the tubular fluid we will get sodium, bicarbonate, glucose, calcium, some other things. Okay, so this is the proximal convoluted tubule of the nephron. This is the descending limb of loop of Henle. This is the thin ascending limb of loop of Henle. This is the thick ascending limb of loop of Henle. This is the early distal convoluted tubules. This is the late distal convoluted tubule. This is the collecting duct system, which is the last part of the nephron. Okay, this upper area, this is the cortex, this is the medulla. So from the cortex to the medulla, your osmolarity is progressively increased, like from the 300, 400, 600, 900 and 1200. Okay, so this green area indicated this area, like proximal convoluted tubules and descending limb of loop of Henle, is very permeable to the water. Whenever you are reabsorbing the ion, the water will follow. Okay, so this area, this thin ascending limb of Henle, limb loop of Henle, thick ascending limb loop of Henle and early distal convoluted tubule, it is the completely impermeable to the water. So when you are reabsorbing the ion, water will not follow. This area, last area, this blue indicates last part of the nephron. It is permeable to the water whenever ADS is present in your blood. Okay, so we will know how in proximal convoluted tubules your sodium, glucose and others ion is being reabsorbed. So see, in the basal area there is one ATPase, that means sodium potassium ATPase. Its function is to decrease the intracellular sodium level and increase intercellular potassium level. So from the tubular fluid, sodium will try to come in by the transporter. With the sodium, glucose and other things will come inside of the cell. After that, this glucose will go to our blood circulation, because this is the basal area. In here you have blood circulation. See, in the luminal side there is also another transporter is called sodium proton antiporter. So sodium will come inside of the cell from the luminar area and proton will go from intercellular area to luminar area. So we know from here we have filtered also the bicarbonate. So this proton and bicarbonate will join and make carbonic acid. After that, in presence of carbonic anhydrase, it will make water and carbon dioxide, and it will come inside of the cell, and inside of the cell you have also carbonic anhydrase. So water and carbon dioxide will again make carbonic acid in presence of carbonic anhydrase. After that, it will dissociate into the bicarbonate and the proton. So bicarbonate will be reabsorbed and proton will again follow this transporter. This is how we are reabsorbing the bicarbonate. So this is the cell of thick ascending limb of Lufo-Fanley. This area is totally impermeable to the water. So in the luminal area of this thick ascending limb of Lufo-Fanley, there is one transporter is called sodium potassium 2 chloride cotransporter. By this we are reabsorbing sodium, potassium and chlorine. So this potassium will go inside of the cell. So intercellular potassium level will be increased. And this this ATPase also increase the intercellular potassium level. So intercellular potassium level will be too much. So these some potassium will also come into the luminal area. So in the luminal area positivity will be increased. So from here we are also filtering the calcium and magnesium. So calcium and magnesium will try to use this route and will try to excrete it in the urine. But in presence of this intercellular positivity, in presence of this tubular positivity, this calcium and magnesium can't use this route. So we know that positivity will refill the positivity. Okay, so this magnesium and calcium will be reabsorbed by the paracellular route, that means between two cells. I have already said this area is totally impermeable to the water. So by this transporter we are reabsorbing the ion, but water can't be reabsorbed. So tubular osmolarity will be decreased. So this is the early distal convoluted tubules. This area is also impermeable to the water. So in the luminal area of this cell has sodium chloride cotransporter. That means from the luminal area sodium and chlorine is being reabsorbed. So see, its basal area it also have the sodium potassium ATPase. So we all already know the function of the sodium potassium ATPase is to decrease the intercellular sodium. So sodium will come from the luminal area to inside of the cell, and chlorine also come from the luminal area to inside of the cell. See, this luminal area there is one channel for calcium. So from the luminal area calcium will come inside of the cell. See, in the basal area there is also one transporter. So by this transporter sodium will come inside of the cell from the outside, because intercellular sodium level is too low. So sodium will come inside of the cell. So by using this energy, this calcium from the cell, it will also be reabsorbed into our blood circulation, because you know this is the basal area. So in this area you also have the blood circulation. So now we will know how parathyroid hormone increase the calcium reabsorption in the early distal convoluted tubules. If parathyroid hormone work on its receptor, this transporter's activity will be increased. So we know this transporter activity is to decrease the intercellular calcium level. So if we increase the activity of this transporter, intercellular calcium level will be too low, because now calcium is being reabsorbed into the blood. So concentration difference will be increased. So from the luminal area, from the high concentration, calcium will come inside of the cell where calcium concentration is too low, and which has been done by this parathyroid hormone. So last part of the nephron, which is permeable to the water when your ADS is present in the blood. That means we know that our ADS is being secreted from posterior pituitary gland. So from there it will come into the blood circulation, and if it work on the cell, then last part of the nephron will be permeable to the water. So last part of the nephron is made of mainly two cells. One is the principal cells, one is the intercalated cell. So we have shown you one principal cells. So we will know in the principal cells how this ion is being reabsorbed. So like all other cells in the nephron, that principal cells basal area, we also have this ATPase. The function of this ATPase is to decrease the intercellular sodium level. So from the luminal area, sodium will be reabsorbed. And we know one function of this ATPase is to increase the intercellular potassium level. So from the cell, potassium will be excreted into the luminal area, and that eventually excreted into the urine. So this is the B2 receptor. So when ADH work on this B2 receptor, from this from this cell we have aquaporin 2, which is the water channel. This aquaporin 2 will attach on this luminal area. So by using this aquaporin 2, water can be reabsorbed. So if we don't have this ADH, and if our B2 receptor is not working, so we can't bring this aquaporin 2 on this luminal area. So water can't be reabsorbed, and like luminal fluid will be increased, which will increase our urine volume. So these things happen in diabetes insipidus patient because they either don't have this ADS, or like their ADS is not working on their kidney. We will know how aldosterone work on these principal cells and its activity. We know that aldosterone receptor present in cytosol. Cytosol. So when aldosterone bind on this cytosolic receptor, it will synthesis use sodium potassium ATPase, and this like sodium channel is called ENaC. So it will decrease the sodium, intercellular sodium, by increasing this sodium potassium ATPase activity, and it will increase these channels. So more sodium can be reabsorbed, and we will tell you later how how this aldosterone also increase this potassium excretion. So in a nutshell we can say that aldosterone action is to increase the sodium reabsorption and is to increase the potassium excretion. So again, what is the action of this aldosterone on this receptor, on this cell? So its function is to increase the sodium's reabsorption and is to increase the potassium excretion. We will know that action of this thiazide diuretics, where it works, how it works, and side effect of these drugs and uses of these drugs. Thiazide mainly work in early distal convoluted tubules. it will inhibit this sodium chloride cotransporter. So this sodium and chloride will not be reabsorbed from the luminal area. So luminal areas sodium and chloride will increase. So it will increase the luminal fluid. Okay, that will eventually increase your urine volume. So see, uses of these thiazides. Thiazide drugs include that hydrochlorothiazide, chlorothiazidone and indapamide. So uses of these drugs. Hypertensions. So hypertension patients, see, our blood pressures depend on like mainly two things, like cardiac outputs and total peripheral resistance. So like our systolic blood pressure mainly depend on cardiac output and diastolic blood pressure mainly depend on this total peripheral resistance. So if we use this thiazide diuretics, it will decrease our blood volume. So decrease blood volume means decrease preload. So see, if we decrease the preload, it will decrease our cardiac output. How? Because our cardiac output mainly depend on two things, like stroke volume and heart rate. So stroke volume depend on three things: contractility, preload and afterload. So by using this drug we have decreased this preload. So we will know how this preload will decrease this cardiac output, that will decrease your blood pressure, because cardiac output mainly depend on two things, stroke volume and heart rate. So if we decrease this preload by this drug, stroke volume will be decreased, that cardiac output will be decreased, blood pressure will be decreased. So one of the use of this thiazide is in congestive heart failure patient. In that patient, our goal is to decrease the workload. So by using this drug we can decrease the blood volume and we can decrease the preload. Preload decrease means workload decrease. So this is how we can help the patient in congestive heart failure. Another use, nephrolithiasis, that means calcium stone. So see, by using this drug we are reabsorbing calcium from the luminal area to interstitial area or in the blood. How this drug increase the calcium reabsorption? If we inhibit this cotransporter, sodium will not be reabsorbed. So that means intercellular sodium level will be decreased. So there is another transporter, sodium calcium transporter. Sodium calcium transporter function is to bring the calcium from like outside of the cell into the cell and bring, and calcium from the intercellular calcium is to kick out the calcium in the blood. So if we inhibit this transporter by this thiazide diuretics, it will decrease the intercellular sodium level, because we are not reabsorbing the sodium. So you know this, if we inhibit this cotransporter by this drug, intercellular sodium level will be decreased, this transporter's activity will be increased. Because of this increase the concentration gradient. So this transporter once function is to kick out the calcium from the cell into the blood. So intercellular calcium level will be decreased by this drug. So concentration gradient between this intercellular area and luminal area will be increased. So from the high concentration area, that means luminal area, calcium will go into the cell. After that, calcium from the cell will be reabsorbed into the blood. So this is how thiazides increase the calcium reabsorption. So how it help in nephrolithiasis? So if we use this drug, luminal calcium level will be decreased. So if luminal calcium level will be decreased, there will be less chance to make this nephrolithiasis. That means calcium stones. Okay. Another use of this drug is in nephrogenic diabetes insipidus patient. Nephrogenic diabetes insipidus patient, this ADS present in the blood, but this cell don't respond to this ADS. So this channel can't be made or can't come on this luminal area, and water can't be reabsorbed, and it will increase the luminal fluid, and that will increase your urine volume. Okay, so our goal in this patient is to decrease this urine volume, and problem is that in diabetes insipidus patient urine volume is increased. So how this thiazide diuretics will decrease your urine volume? So if we block these thiazide diuretics, if we block this transporter by this thiazide diuretics, the sodium and chloride will not be reabsorbed. That means our blood's osmolarity will be decreased. So this area, proximal convoluted tubules, will try to compensate. That means it will increase this transporter activity. That means it will increase that ions reabsorption. So as ion reabsorption will be increased, that water reabsorption will be increased. That means from this area tubular fluid will be decreased. That means tubular fluid decrease means urine volume decrease. So we can say that in all other cases thiazide works for increasing this urine volume, but in nephrogenic diabetes insipidus patient it will decrease your urine volume. Then that will be helpful for nephrogenic diabetes insipidus patient. So side effect of this thiazide, hypokalemia. So how this thiazide will causes the blood potassium level? Okay, if we use this thiazide, it will inhibit the sodium and chlorides transporter. Then sodium and chloride will not be reabsorbed. So more sodium will come in front of these principal cells. So more sodium will be reabsorbed. So this ATPase activity will be increased. So ATPase activity increased mean more potassium come in the cell. So as more potassium come in the cell, then more potassium will be excreted because of this concentration gradient. Another way to explain this, if we block this transporter, then chloride is negative ion, so it will also attract this potassium. Another explanation, so if we inhibit this transporter, sodium chloride in tubular fluid will be increased. That means tubular flow will be increased. So more potassium will be washed out from this area. That means which was in front of this principal cells, it has been washed out because of increased tubular flow. So concentration gradient will be increased because from this area concentration is high and this area's concentration is low. So from this area potassium will come into the tubular area and it will eventually excrete. That means we are losing the blood potassium. So in a nutshell, we can say whenever we are reabsorbing the sodium, at the same time we are also excreting the potassium. This is the principles. Another principles. Whenever we are excrete the potassium, that means we are also excrete the proton also. This is the another principle. So whenever we are reabsorbing the sodium, at the same time we are also excreting the potassium. So side effect of this thiazide is alkalosis. So we know that by using this thiazide diuretic drugs we are increase the sodium reabsorption by these principal cells. So whenever we are reabsorbing the sodium, we are also excreting the potassium. This is the principle. And another principle, if you excrete the potassium, you are also excreting the proton. So proton excretion means we are losing the proton, that will make our blood alkalosis. Okay. Side effect of this thiazide is hypercalcemia, because we have already shown you that it will increase the calcium reabsorption. So eventually this calcium will go into our blood circulation, that will increase our blood calcium level. And another side effect is hyperglycemia. And I am telling you that if blood's potassium level decrease, and at the same time insulin level will be decrease. Insulin level will be decreased. So by using this drug, we are making the blood potassium level decrease. That means insulin level decrease. So enough insulin is not present in our blood to bring the glucose into our muscles and fat cells. Okay, so blood glucose level will be increased. Glucose level will be increased, that we called it hyperglycemia. Okay, actions of the loop diuretics. Like loop diuretic includes the furosemide, torsemide and ethacrenic acid. So uses of the loop diuretics. Acute pulmonary edema. That means if we use this loop diuretics, it will work on this thick ascending limb of loop Henle cell. So it will inhibit this sodium potassium to chloride co-transporter. So you are losing this ion. That means losing this ion means you will also lose the water, that will decrease your blood volume. That means it will also help in this acute pulmonary edema and another things. It will be helpful in heart failure patient. How? If we use this drug, these ions will not be reabsorbed, and at the same time we will increase the urine volume. Water will follow. Then that will decrease our blood volume. See, in heart failure patient, our goal is to decrease the workload. So if we decrease this blood volume by using this drug, it will decrease your preload. And preload decrease means your workload decrease. So now by using this drug, we can fulfill our goal. That means we are decreasing preload, that will decrease our workload. And another things, we also can use this drug in hypertension patient. In hypertension patient, our goal is to decrease our blood pressure. So our blood pressure mainly depend on cardiac output, total peripheral resistance. So see, by using this drug, we also can decrease the blood. We decrease the blood volume. So blood volume decrease means your preload decrease, because preload depend on your blood volume, and preload decrease means your cardiac output decrease. How? Cardiac output depend on two things: stroke volume and heart rate. And stroke volume depend on contractility, preload, afterload. So by using this drug, we are decreasing the blood volume, that will decrease the preload. Decrease preload means decrease stroke volume. Decrease stroke volume means decrease cardiac output. Decrease cardiac output means decrease blood pressure. Can use this drug in hypercalcemic state. How? If we inhibit this transporter, potassium will not be reabsorbed. That means intercellular potassium will not be too high. Then not more potassium will come in the luminal area, and this potassium will not refill this calcium and magnesium, because this luminal area potassium is too low. That means positivity is low, so it will not this magnesium and calcium ion, it will not force this magnesium and calcium ion to be reabsorbed through this paracellular road. So what is the result? So these luminal calcium and magnesium will be excreted into our urine. That means we are losing the calcium. So in hypercalcemic state, problem is that blood calcium level is too high. So by using this drug, we are decreasing the blood calcium level. Side effect of this drug is hypokalemia. See, by this drug we are inhibit this transporter. Inhibit this transporter, that means we are not reabsorbing the sodium, potassium and 2 chloride. That means these sodium, potassium will and 2 chloride will be present in front of these principal cells. So more sodium will be reabsorbed. So more sodium will be reabsorbed by these principal cells, this sodium potassium ATPase activity will be increased. So ATPase activity is sodium potassium ATPase one activity is to increase the potassium, intercellular potassium level. So more potassium will be excreted. And another thing, we are also excreting this chloride, so it carries the negativity. So this negativity will attract this potassium ion to be excreted, okay, from the cell into the lumen, and it will be eventually excreted in the urine. By using this drug, we are increase the tubular flow. Tubular flow increased means we are washing out the tubular potassium level from this area. So concentration difference will be increased, because from here you already washed out that potassium. That means concentration difference between this intercellular potassium level and luminal areas level will be increased. So more potassium will be excreted into the urine, and this will make the hypokalemia. One principle: whenever you lose the potassium, at the same time you are losing the proton. So by using this drug, as we are excreting the potassium, at the same time we are also excreting the proton, that will make alkalosis. Another side effect is hypocalcemia. This hypocalcemia, because see, by using this drug we are not reabsorbing the calcium, so calcium will be excreted into the urine, so blood calcium level will be decreased, that will lead to the hypocalcemia. And hypomagnesemia, that means blood magnesium level is decreased. See, by using this drug we are no more like reabsorbing this magnesium, so magnesium will be excreted into the urine, and our blood magnesium level will be decreased. And another side effect is ototoxicity. So ototoxicity means hearing loss, balance loss. This drug will causes this ototoxicity. So now discussion is potassium sparing diuretics. Definition of the potassium sparing diuretics: the drug that don't promote the potassium excretion. Okay, so we can use the spironolactone as a potassium sparing diuretics because it blocks the aldosterone receptors. So we know how this spironolactone, that means aldosterone receptor blocker, work and its uses and its side effect. Hyperaldosteronic state: if our blood has high aldosterone level, so by using this drug we can inhibit the aldosterone's activity. And another thing, adjust to potassium sparing diuretics. We know these loop diuretics, thiazide diuretics, this all causes the potassium excretion. That means it makes the hypokalemia. So with this drug, we also can use this potassium sparing diuretics, that means spironolactone, to prevent the hypokalemia. Anti-adrenergic use, that means female hirsutism, because it inhibits the androgenic receptor. And congestive heart failure, what the use of this? We know that aldosterone will causes the cardiac remodeling. So if we block this aldosterone receptor, by this spironolactone, it will not causes the cardiac remodeling in heart failure patient. And side effect: because of this drug we are not losing the potassium, so it makes hyperkalemia, that means blood potassium level increase. Okay, so we know one things. So whenever we are like excrete the potassium, at the same time we are excreting the proton. Okay, so as we are not excreting the potassium by this drug, by using this drug, and we are not excreting the proton, so increased proton level in the blood will causes the acidosis. Another two potassium sparing diuretics is like amyloid and triamteric. Amyloid and triamteric will block this sodium channel is called ENaC. So as we are not reabsorbing this sodium in the cell, and by using this drug, so intracellular sodium will not increasing, so this ATPase activity will not be increased. So like this potassium is intracellular potassium will not be increased, so potassium excretion will not occur. Okay, so we can say by using this drug we are excreting the sodium, but we are not excreting the potassium. Sorry, by using this drug we are not reabsorbing this sodium, that means we are excreting this sodium, and by using this drug we are inhibiting this potassium excretion. And another things, we use this drug with this loop diuretics and thiazide diuretics because this causes the hypokalemia, and hypokalemia means blood potassium level decrease. So to prevent the blood potassium level decrease, we can use this amyloid and triamteric as a potassium sparing diuretics. Okay, and one side effect of this, it will causes the hyperkalemia because we are not excrete the potassium, so blood potassium level will be increased. And it will also causes the acidosis. How? Because when we know one principle, so when we are excrete the potassium, at the same time we are also excrete the proton. So as we are not excreting the potassium, we are not excreting the proton, then that will make our blood acidosis. Okay, now we will discuss that carbonic anhydrous inhibitor like acetazolamide and dorzolamide actions. Okay, seen proximal convoluted tubules has carbonic anhydrase. So if we inhibit this carbonic anhydrase by this acetazolamide or dorzolamide, okay, so we can't make this proton by running this reaction. So we our this antifutter will not work. So we can't reabsorb this bicarbonate into the blood, and at the same time we also can't reabsorb this sodium. And you know that as a diuretics this carbonic anhydrase inhibitor action is very weak, and we use this carbonic anhydrase inhibitor like acetazolamide, dorzolamide in glaucoma patient. Glaucoma patient, what's the problem? Increase intraocular pressure. Okay, so by using this drug, it will decrease the aqueous humor production. So as we are decrease the aqueous humor production by using this drug, that will correct our increased intraocular pressure and pressure. That will correct our intraocular pressure, that will be helpful in glaucoma. Okay, again, in glaucoma patient, carbonic anhydrase inhibitor will inhibit the production of this aqueous humor. Aqueous humor production decrease mean intraocular pressure decrease, that means it will help in glaucoma patient. And acute mountain sickness and metabolic alkalosis. Okay, as we are losing this bicarbonate into the blood, that means we are not reabsorbing this bicarbonate in our blood. So our blood bicarbonate level will be decreased, so it will helpful in this too, metabolic alkalosis. And side effect, bicarbonate urea. Okay, we know that as we are not reabsorbing this bicarbonate by using this drug, carbonic anhydrase inhibitor like acetazolamide and dorzolamide, so this bicarbonate will be lost in our urine. So bicarbonate urea will be produced. Okay, one of the side effects of this carbonic anhydrase inhibitor is acidosis, because by using this carbonic anhydrase inhibitor we are not reabsorbing this bicarbonate into our blood, so blood bicarbonate will be decreased, that will lead to the acidosis and hypokalemia. So by using this drug we are increasing the tubular blood flow, and tubular blood flow will increase tubular blood flow will increase the potassium excretion, that will lead to the hypokalemia. And renal stone is very important, because by using this drug we are making our tubular fluid alkalosis, and alkalosis will promote the calcium phosphate stone. And again, by using this drug we are making our tubular fluid alkalosis, because we are like leaving this bicarbonate in our tubular fluid. So our tubular fluid will be alkalosis, that will lead to the renal stone, that means calcium phosphate stone, because the tubular alkalosis will promote the calcium phosphate stone. Osmotic diuretics like mannitol, if we inject the mannitol intravenously, it will increase the blood osmolarity. So in uses of this is to decrease intraocular pressure in glaucoma patient. If we inject this in our blood circulation osmolarity will increase, that will flow the water into the blood circulation. If this is our eyes tissue, and after using this mannitol, blood osmolarity will be increased. So this increased osmolarity